Yes, sir.
Good evening, faculty members. Good evening, delegates and doctors for joining Shield Connect. And today we are back with our series, Tuesday Tea Time, that is Learning Simply with Dr. Kavita Bapat ma'am. And before we start with this session, let me introduce coordinator of this series, Dr. Richa Narkade madam. Ma'am is gynecologist and obstetrician. So I hand over this session to Dr. Richa ma'am. Thank you, ma'am.
Thank you, Team Shield. Thank you for this platform. I welcome Dr. Kavita Bapat, whose brainchild is this webinar, Tea Time with Kavita Bapat. She is director of Bapat Hospital and one-day hysterectomy specialist. Vice President Foxy 2021 and 22, Director of Bapat Hospital, Organizing Secretary AICOG 2022, Indore, one-day hysterectomy specialist, ICOG vaginal surgery certified course provider, Jogi peer reviewer, initiate registry of primary ovarian insufficiency, editor of Apollo Medicine, World Book record for contributing in many medical services, and many healthcare awards by Dainik Bhaskar, Naika, and Vice President AM POG, Chairperson Breast Committee Foxy 2016 and 18, Vice President MP Chapter of Vaginal Surgeons, Member of Urogynecologic Committee AOFOG 22-22-24, Executive Member of ISAR and IAG. And we are having our guest today, Dr. Brijbala Tiwari ma'am. She is President of Indore Society, Obsgyne Society, Vice President, Indian Medical Association, Indore. So I welcome you,
And she's
ma'am.
contesting for the post of Infertility Committee Chair this year. Yeah.
Now,
Allow me to share
Kind
the screen.
introduction. Thank you, Richa.
Allow me to share the screen. Yeah. Thank you so much. So thank you so much, Richard. Without wasting much time, I don't like on this topic, but the most important point, again, the glorious vision, this we talk about, and we are discussing today. The topic is thyroid storm. So the case one, that's a 24-year-old, 12 weeks pregnant, background of Graves' disease for 5 years, was on carbimazole, but she discontinued since she became pregnant. Presented with nausea, vomiting, and altered mental status for 1 day, and she was afebrile, normotensive, but she was tachypnic, tachycardia with heart rate of 150 beats per minute and confused. We are talking today about thyroid storm. It's a very unusual condition. All will agree with me, but still, these are the conditions as a knowledge we should know. Now, investigations being done showed supraventricular tachycardia aborted by this adenosine and aminodrone, TSH less than 0.1, free testosterone more than 100, normal baseline liver function and complete counts. In emergency department, she was diagnosed and managed as for the thyroid storm with hydrocortisone, propranolol, propylthyrouracil, PTU, iodine solution, and cholestyramine. Then suddenly she deteriorated, requiring intubation and vasopressor support under care of medical intensive care unit. Progressed to multi-organ failure. She had acute liver injury, acute kidney injury, and she ended up into DIC. So PTU was stopped and started on plasma exchange, followed by total thyroidectomy and tracheostomy. Sonography showed non-viable fetus, so dilatation curettage was done. Afterwards, she markedly improved, except her conscious level, and kidney functions required hemodialysis. MRI brain show small subdural hematoma, treated conservatively, and Wernicke's encephalopathy treated with thiamine and substantial response of spontaneous breathing. Post-thyroidectomy, she required calcium supplementation and levothyroxine, and liver function and coagulation parameters back to baseline. So you can understand how the bad situation, being not treated properly before, and this type of patient becomes pregnant, and it's really a rare condition, but everyone should know about this condition. Thyrotoxic crisis is a medical emergency and characterized by acute exacerbation of the signs and symptoms of hyperthyroidism. It's a rare complication, and occurring approximately 1% of the pregnant patients who are having the hyperthyroidism. So it's really unusual. In a lifetime of a senior OBGYN also, once in a while, they must have seen this type of patients. Associated with a significant maternal and perinatal mortality and morbidity, and the vast majority of women presenting thyroid storm have a history of hyperthyroidism. So thyroid storm should have the history of the hyperthyroidism, but sometimes the hyperthyroidism is also diagnosed during the pregnancy and patient can come with a thyroid storm also. And hyperthyroidism reverses the clinical state resulting from excess production and exposure of thyroid hormones. So very, very simple. Only two things: excess production and exposure of thyroid hormones. Now, Graves' disease, most common of which accounts 95% of all cases of hyperthyroidism in pregnancy, caused by circulating thyroid stimulating autoantibodies. This is the one thing. And the clinical signs are ophthalmologically, they have exophthalmos, they have lid lag, they have lid retraction also, and dermatopathy is that there is a peritibial edema, are very specific of Graves' disease. So we don't see this type of diseases, but these are very important. Now, other causes of hyperthyroidism in a pregnancy other than the Graves' diseases, number one, if there is an inflammation of thyroid gland, that's a thyroiditis. It can be toxic multinodular goiter. It can cause the hyperthyroidism. Solitary toxic thyroid nodule, hyperemesis gravidarum, and gestational trophoblastic disease end up into the thyroid storm if the patient is already having the hyperthyroid. Then ingestion of exogenous thyroid hormone and TSH secrete pituitary adenoma. So these are the other causes for all this. In order to minimize the complication, including thyroid storm, hypothyroidism is best diagnosed and treated prior to pregnancy. So the patients who are planning to become pregnant and having the hyperthyroidism, they should be rightly diagnosed and treated before the pregnancy. And they should have some inciting event also. They can have infection, hypoglycemia, diabetic ketoacidosis, venous thromboembolism, surgery or labor or delivery can be identified many instances for the thyroid storm. So probably this patient is already being diagnosed and treated before pregnancy for hyperthyroidism. But these are the few things that can end up the patient again into thyroid storm because of infection, hypoglycemia, diabetic ketoacidosis, and all those things. To diagnose the combination of symptoms and signs, patients with thyrotoxicosis, they have a fever, tachycardia out of proportion to the fever, more than 140 to 160 beats, and the altered mental status is another point, such as she must be having restlessness, nervousness, confusion or seizures, diarrhea, vomiting, and cardiac arrhythmias. However, the diagnosis can be difficult to make clinically. If the things are in a mind, if the investigations are there, if the known case is there, the chances are to diagnose properly. But still, as a patient can be having the hyperemesis gravidarum, she may be having vomiting, cardiac arrhythmias, maybe with the hyperemesis gravidarum, restlessness, nervousness, and confusion can happen with hyperemesis gravidarum. So we should be able to differentiate between the thyroid storm and the hyperemesis gravidarum. But if thyroid storm is suspected, serum thyroid functions are done and should be sent immediately. Biochemical findings supportive of the diagnosis include suppressed level of thyroid binding globulin, it's a less than 0.05, an increased level of T4 and T3 in the maternal circulation. So these are the more important things. Most women with a Graves' disease will have circulating anti-TSH receptor, anti-microsomal receptors, and anti-thyroid peroxidase and autoantibodies. But the measure of such antibodies is neither required and nor recommended to establish the diagnosis. We can start the treatment and then all these things can be done. Antibodies levels do not correlate well with the maternal and perinatal outcome also. So the differential diagnosis includes, there can be anxiety disorders the patient can be having, drug intoxication or withdrawal. The patient can have a pheochromocytoma. This is another important point. And it is associated with the significant maternal and perinatal mortality and morbidity, including shock, stupor, coma, death, and a clinical index suspicion of thyroid storm is high. And treatment should be initiated immediately, should be withheld pending the results of biochemical tests. So all those things with a thyroid storm, it should be treated in the emergency department and it should be done fine. Now, what are the goals when we have the thyroid storm patient are? There are two terms. We have to reduce the synthesis and release of hormone of the thyroid gland, and we have to block the peripheral action of the thyroid hormones. So how it has been done? To reduce the synthesis and release of the hormone, use the thiamides or the supplemental iodide or glucocorticoids. And we want to block the peripheral action of thyroid hormones using the glucocorticoids, PTU and beta blockers are also important. Now, to treat the complication and support the psychological function and to identify and treat the precipitating events. For example, when we want to treat the complication, it should be managed in ICU setting. Acetaminophen, cooling blankets, supplemental oxygen, fluid and caloric replacements are important. But to identify and treat the participating events, like patient may be having hypoglycemia, embolic events, or she is in a diabetic ketoacidosis, this all should be identified and treated associated with. Now, the goals with other acute maternal illness, fetal well-being should be appropriately evaluated, consideration given to delivery if appropriate. Fetal tachycardia more than 160 is sensitive index for the fetal hyperthyroidism. Only 1 to 5% neonates born to the women with a poorly controlled thyroid will develop transient hyperthyroidism or neonatal Graves' disease caused by the transplacental passage of the maternal antibodies, antithyroid antibodies. Once the patient is stable, follow the serum electrolyte levels, especially the potassium. ABG is very, very important too early as indicated. Catheterize the patient if she is unconscious or not passing urine, and to decompress the stomach if she is unconscious, and to continue the fetus surveillance. For women who fail to respond to the initial medical therapy, options are very, very limited. We feel sorry for these type of patients. If it's the initial medical therapy, she is not able to treat, then the radioactive iodine 1311 administered to ablate the thyroid gland is absolutely contraindicated in pregnancy. For the pregnant patient, thyroid storm, save the God to us. She should respond us in a first initial therapy. Otherwise, the problem will be more because it will permanently damage the fetal thyroid. The surgery is best avoided, but sometimes it is required. Now we have the second case. This is the first case which we are having the early pregnancy. Now this is the case, unbooked patient admitted in an emergency room, second stage of labor, gravida 2, parity, 30 weeks of gestation only. Singleton live intrauterine, superimposed preeclampsia with severe features of history of uncontrolled thyroid disease. Patient was diagnosed as hyperthyroidism since 5 years before admission, but how to proceed, examination, and what are the investigations should be done and how to be managed. Urgent admission, general condition, state of consciousness, Glasgow Coma score consists of 3 for the eye-opening response, 4 for the verbal response, and 5 for the motor response score. Urgent measure to control blood pressure, heart rate, temperature, increased respiratory rate, SpO2 in room air. These are the. Now, how to proceed for the diagnosis? General examination, had a bilateral protruding eye suggesting of exophthalmos. Diffuse trauma on the neck was palpable, which is no bruit. Auscultation in the both lungs, grade 3 to 6, loudest on the apex and the rails of bilateral bottom side of the lungs. Now, diagnosis, extremities warm, bilateral pitting edema, proteinuria 2, hematuria 1, electrogram showing sinus tachycardia, low thyroid stimulating hormone, fundal height 30 centimeter, regular contractions, 4 times 10 minute duration and 45 seconds, fetal heart rate 40 beats per minute. Vaginal exception, Bishop's stone, membrane intact. So blood gas analysis, urine analysis, all the urea creatinine levels, sorry for the spelling, then aspirate aminotransferase, then alanine aminotransferase level ALT, AST should be done. Blood gas analysis in such cases, increase of pH, SCO3 decrease, PCO2 decrease. Now, if the patient with a thyroid surgery, this is the algorithm we should follow, and we should see how to do it. See, first confirm the diagnosis, identify the women at the risk of developing thyroid storm, perform a detailed history and a physical examination, and check the thyroid function test. Unable to confirm the diagnosis, consider other diagnosis, confirm gestational age, document fetal bleeding, and manage as an outpatient continued still control of hyperthyroidism. But If the diagnosis of thyroid storm is confirmed, admit the hospital immediately, confirm the gestational age, document the well-being, exclude infection as a cause of thyroid storm, consider taking blood culture, urine culture, and X-ray test. Institute treatment immediately. Patient needs ICU setting with 15-minute maternal vital signs to be seen. EKG, face mask oxygenation, supplementation is 4 to 6 liters per minute. Continuous fetal monitoring if more than 24 weeks of gestation. Very simple. Then what to start in initial drug therapy? These are the drug propyl thyrouracil, 600 to 8 milligram, 800 milligram stat, then 150 to 200 orally every 4 to 6 hours. And if oral administration is not possible, use methimazole rectal suppository. Starting 1 to 2 hours of PTU, administer saturated solution of potassium iodide, 2 to 5 drops orally every 8 hours. An alternative source of iodine may include sodium iodide or Lugol solution, or the lithium carbonate should be given. Dexamethasone 2 milligram IV every 6 hourly for 4 doses. Propranolol is very important, 20 to 80 milligram orally every 4 to 6 hours, or 1 to 2 milligram IV every 5 minutes for total 6 grams. And then it should be, if the patient has a history of severe bronchospasm, consider Respirine or glutathione. And then phenobarbital, 30 to 6 milligram orally every 6 to 8 hours as needed for the extreme restlessness. Once the patient is stable, continuous close observation is needed. Thank you so much for the patient listening, and thank you so much for being here today. The topic is thyroid storm, and I like Dr. Brajbala Tiwari to Braj, please unmute yourself.
It was so concise and excellent talk, and you covered in such a short time very uncovered, unspoken topic. I remember a case around 12 years back. Patient was hypothyroid and she was taking altroxin 100 microgram daily without getting checked in between since long 1 year. And she got pregnant, and she was a rural patient. She brought to hospital at 10-12 weeks, because in the rural setting they think that after 3 months we have to go to hospital, although we have inverted pyramid and all, but it's still the it's long back history. They brought her at 12 weeks, and she was having 103 temperature, 140 pulse, and she was dehydrated, managed in ICU, and we couldn't save the baby, but we could save mother. So it is very important to think about this uncommon condition, and which is really very severe medical emergency, and it needs multidisciplinary approach and proper investigation. So it's really very well covered topic. Thank you so much.
Thank you everyone who has joined over here. I don't want to spend much time on discussing the, we'll have to discuss if anybody is having a question in a chat box. Otherwise, we can cover this type of topics every Tuesday as a tea time in 20 minutes and a different variety of topics. And it will be, I think, learn simply will be a good thing for me. So thank you so much, everyone who has joined today. I'm so happy.
Question with Dr. Neeta Agrawal, is hypothyroidism or hyperthyroidism an indication for progesterone supplement during first trimester?
I think for the pregnancy continuation, progesterone, if needed, should be given, if though she is needed the hyperthyroidism or the hypothyroidism, for both she's asking. But if the we are talking here about the thyroid storm, am I right? So in a thyroid storm,
in hypothyroidism, there is luteal phase defect. So in that we sometimes need, because there is hyperprolactinemia along with hypothyroidism. So sometimes we need to give progesterone support to prevent
the medical emergency. Am I right? And to continue the pregnancy. Yeah, we have done the recording of this presentation, and everybody can see on the YouTube also. So I'll post the link on it whenever get a chance. Otherwise, everybody who are there can directly message me on my inbox and have a good chat over there. So thank you, Shield, once again for giving us the chance. Today's topic is thyroid storm, and every week we are having tea time only for 25 to 30 minutes maximum, and I'll be happy to share with you this thing, one expert and this thing. Thank you so much, Sheil. Thank you, Richa. Thank you, Braj, for being with me.